In this lesson, we're going to talk about polyhydramnios and amniotic drainage. We will be following a clinical case. It was a woman of 35 years old. She had hypothyroidism. She had a miscarriage, but besides that, everything was normal. The fetus had a low risk of Down syndrome. She had an ultrasound at 20 weeks, which was normal, and at 25 weeks she went to the ER because she felt a huge abdominal distension. At the physical examination, an uterine height above what corresponded to 25 weeks claimed our attention. So the resident came to us with this photo, and we asked him how he would evaluate the amniotic fluid. Subjectively, or measuring the single deepest pocket, or measuring the amniotic fluid index. In this clinical case, we measured the amniotic fluid index. And why did we measure the amniotic fluid index? Reviewing answer by answer subjectively is absolutely incorrect. If we think the amniotic fluid is increased or decreased, we have to measure it somehow. We can measure the single deepest pocket, which is look in all the amniotic fluid, the deepest one, and measure it. Or measure the amniotic fluid in the four quadrants. In both cases, it's important that the transducer is perpendicular to the abdomen. Measure all the columns of more than 1 centimeter and not include umbilical cord or fetal parts. And which will be the advantages and disadvantages of measuring each of them? When we measure the single deepest pocket, the normal values are between 2 to 8 and 10 centimeters. It can be measured at any gestational age. We can measure it in twin pregnancies, and it's very useful as a screening tool. For example, in the second trimester ultrasound or in the third trimester ultrasound, we can measure the single deepest pocket. In low-risk pregnancies, in which we think the amniotic fluid is normal, but we want to keep the record of the amniotic fluid. On the other hand, when we measure the amniotic fluid index, it's more sensible and more specific. The normal values are between 5 and 25. To measure the pregnant woman has to be of more than 24 weeks, because we have to measure the 4 quadrants, and below 20 weeks, the uterine height doesn't reach the umbilicus. So we're logging 2 quadrants, and it's especially used in screening of high-risk pregnancies, in which we suspect pathology. Also, to manage and follow up. We know that polyhydramnios is of more than 25. We can classify it as mild, from 25 to 29, moderate, from 30 to 34, and severe, equal or more than 35. So as conclusion, it is helpful to define polyhydramnios for its management and follow-up, and also allows to classify it. In our case, we measured the amniotic fluid index, and it resulted in an amniotic fluid of 30. It is a moderate polyhydramnios. This is a graphic that reflects the association between perinatal mortality and the maximum vertical pocket depth. And we can see how with a normal amniotic fluid there is no mortality, and how with a few amniotic fluid or with too much amniotic fluid the mortality increases. In a linear way, the more liquid it is, the more mortality rate it has. So it is relevant that the amniotic fluid index is of 30. Well, yes. And it is also an indirect sign of fetal well-being. And where does the amniotic fluid comes from? We know that the major part of the amniotic fluid is urine. The producer of amniotic fluid is the fetus itself. And there is a little quantity that comes from the trachea. And how does it reabsorb? Its principal way is through fetal swallowing. But there is other little part that goes to the placenta, so it turns over with swallowing and reabsorption. As a result of this, when there is an alteration in the amniotic fluid, it can be due to any of these regulatory aspects, so too much production or less reabsorption. So if we have a polyuric or hypervolemic fetus, we could have a polyhydramnios. This is what typically happens to twin-to-twin transfusion syndrome. It also could be a problem of swallowing, that this fetus had a problem, an obstruction, tumor, congenital diaphragmatic hernia that impedes the swallowing, and this causes the polyhydramnios. There can be also a placental alteration, and since the placenta performs some reabsorption of the amniotic fluid, it could cause a polyhydramnios. So, which are the causes that could explain a polyhydramnios? In our case, what could be the cause? In 25% of them, there is maternal cause, hypervolemia, for example, a diabetes or RH isoimmunization, in which the fetus is anemic. So, to compensate, is hypervolemic, and this produces the polyhydramnios. Then we have fetal causes, something that causes swallowing difficulties, neural muscle problems, anemia, congenital heart defect. So we have to rule out the presence of malformation, infections, as the one by parvovirus B19, or chromosomopathies. The muscular dystrophy of Steiner, which are fetuses that don't move and don't swallow and accumulate amniotic fluid. Or even a twin-to-twin transfusion syndrome, and then a small percentage of placental alterations, basically tumors as the chorioangioma. So having these causes, we will have to rule out one by one. Following guidelines, when having an amniotic fluid index of 30, what should we do? The first thing is to try to find the cause of it. Ask for a maternal blood sample. Perform a TTOG to rule out diabetes. Coombs to rule out isoimmunization, and serologies to rule out infections. And what else can we do? Try to rule out the fetal causes. Perform a fetal placental ultrasound. Very important to assess the Doppler of the medial cerebral artery, the systolic peak, to rule out anemia. Study the fetal anatomy. See the fetal movements to rule out neuromuscle problems. See the gastrointestinal system, the thorax, heart, kidneys, and central nervous system to see if we find some explanation as obstructive malformation, polyuric fetus or central nervous system problem that could explain the lack of swallowing, and finally, see the placenta to rule out a chorioangioma. Finally, in some cases, as the severe polyhydramnios, an invasive procedure can be performed to rule out chromosomopathies with molecular karyotype and QF-PCR. And in specific cases in which we suspect a neuromuscle problem, we can ask for the specific mutation of Steiner or of myotony dystrophy. We could also assess electrolytes or aldosterone. We can also look for PCR of virus of a positive maternal serology, and if we suspect a metabolic syndrome, look for metabolites. And to assess well the polyhydramnios, we have to classify it. And now, how severe is the polyhydramnios? If we talk about normal amniotic fluid between 5 and 17, high normality limit will be 18 and 24. And above 25, there is polyhydramnios. The majority of them are mild, in 70% of cases, and moderate and severe is less frequent, especially the severe one, only 30% of cases. And why is it important to classify them? Because the probability of anomalies will increase with the severity. With mild polyhydramnios, the rate of associated anomalies is only 6%. But in moderate or severe polyhydramnios, between 50 to 65% of cases, we will detect an associated anomaly, a malformation, anemia, infection. So in our case of moderate polyhydramnios, we have to make the effort to try to find the cause, because it is likely to find something. And which is the study we will propose? If we have an amniotic fluid in the superior limit of normality, we will perform with consciousness a fetal ultrasound. And in a mild polyhydramnios, we recommend to perform the maternal serologies and the fetal ultrasound. And if it is severe or moderate, we could think of genetic test, and also ask for echocardiography and neurosonography. And this was what we did with the fetus of 25 weeks. With moderate polyhydramnios, TTOG was normal, negative Coombs, and negative serologies. So we rule out diabetes, nor isoimmunization, nor infection. And in the ultrasound, the assessment of the medial cerebral artery Doppler was normal. But we did detect an oropharyngeal tumor. As we can see in the fetus, was always with its mouth partially opened, and this tumor inside. This is an actual section in which we see this tumor here. So, what will we do? Follow up in 2 weeks, hospital admission and fetal maturation, amniotic drainage, or complete the ultrasound. So I put this question to remark that we have to complete the ultrasound assessment. We have to know the reason of polyhydramnios, but also see the consequences of it. So we have to evaluate the cervical length. Something is the cause and other thing is the consequence. It could be a non-severity cause, but although it's a mild polyhydramnios, this could cause a shortening of the cervix, and this could end in a premature delivery, which will condition the prognosis of this fetus. So it is highly important every time we have a polyhydramnios to assess the cervical length, at least every week or every 2 weeks, depending on the severity. In this case, the cervical length was of 35, so we can be calm about the prematurity delivery for the moment. Never forget about cervical length assessment. In this case, as a summary, we perform the maternal blood sample, the ultrasound, and we add the surveillance of amniotic fluid index, so to see if the polyhydramnios is more severe or not, and remember the cervical length. Continuing with our algorithm, moderate and severe polyhydramnios are the more infrequent, but also the ones with more associated anomalies. We have to do a fetal scan and also assess the cervix. How frequent will be the follow-up? Every 2 weeks, but in the case there is a moderate or severe polyhydramnios, every week. Why? Because it can evolve, or the cervix can be shortened, and which will be the treatment? It will depend on the cause. If it is anemia, treat the anemia. If it is infection, see the prognosis of infection. If it is isoimmunization, treat the isoimmunization. But we do know that there is a specific treatment for polyhydramnios, that is taking out the amniotic fluid, especially if it has repercussions. So, which will be the indications of amniotic drainage? Pregnancies under 35 weeks. And why 35 weeks? Because if we are at 37 weeks, there is no reason to perform the amniotic drainage. Instead, we will deliver the baby. But if we are below the 35 weeks and we evidence a cervix shortening or produces symptomatic contractions or maternal discomfort, independently of the cause, we can think of an amniotic drainage. So in case we cannot treat the cause, we have to plan the course of action. We have to try to gain weeks, perform this amniotic drainage, and maybe we will need to perform another one to try to reach term and treat the cause once it's born. In this case, we follow up this pregnancy from 25 to 28 weeks with weekly surveillance of amniotic fluid index and cervical length. At 20 weeks, we evidence an amniotic fluid index of 38 in severity parameters. Cervix length passed from 35 to 13, and besides that, the mother couldn't sleep, had problem breathing, so we decided to perform an amniotic drainage. So which will be the technique and needle used? An 18G needle with rapid aspiration. And why? Because the main risk of an amniotic drainage is the consequent premature delivery, and studies have shown that we could do it quicker than possible, and this will reduce the risk of premature delivery. How do we do it? The most important part is the preparation. We have to put a venous catheter in the mother, check the serology as any other invasive procedure. We put prophylactic antibiotic 1 to 2 hours before the procedure. We can also put tocolytic, especially if there are uterine contractions. In our case, we have outpatient nifedipine to prevent premature delivery. If the pregnancy is of more than 24 weeks, assess the necessity of long maturation, because the majority of amniotic drainage will go well, but some of them can have complications. And then, prepare the material with a checklist. So before making the puncture, we need to have everything in place. How we perform the procedure? We'd rather do it with the patient in semilateral decubitus, because usually these patients will become dizzy, with ultrasound monitoring, and looking for the space of more liquid without touching uterus fundus, because in this giant uterus, while the fluid is being aspirated, the uterus will be smaller and smaller, and so the fundus will be going down. So the advisable thing in the middle of the abdomen. Asepsia local anesthetic because we use an 18G needle and that hurts, and rapid aspiration with vacuum system. We always do our best to perform this procedure in less than 30 minutes. The more time we take, the more complications it will have, so the quicker the better. Our objective will be to have at the end amniotic fluid index of less than 20. And then we will perform a post-procedure follow-up. The complications are infrequent, around 2% of cases, which are premature rupture of membranes or abruption placenta. We leave the patient in observation with NST, and then we leave the patient hospitalized with tocolytic treatment dependent on the clinical evolution. Most of cases, the amniotic drainage is done in the morning, and in the afternoon the patient is discharged. In our patient, we performed the amniotic drainage, and in 15 minutes we took out 3 liters and we sent the amniotic fluid to analyze the QF-PCR. Then she was with a 12 centimeters of amniotic fluid index and a cervical length of 30. At 31 weeks, the severe polyhydramnios reinstituted with 42 centimeters of amniotic fluid index and a cervical length of 5 millimeters. So we performed a second amniotic drainage, and we managed to reach 35 weeks, with once again an amniotic fluid index of 40 and a cervical length of 4 millimeters. So at this point, what should we do? Another amniotic drainage, surveillance, induction of labor, or an exit C-section? In this case, our option was to perform an exit C-section. Let's talk briefly about it. In our case, we had this oropharyngeal tumor that occupied all the mouth. First fact is that was already performed 2 amniotic drainage, and we could perform another one, but we were at 35 weeks of pregnancy, and we could leave the patient to start a spontaneous delivery or induced labor. But having this oropharyngeal tumor, the best option is the exit C-section. It's an elective C-section with general anesthesia to the mother, which relaxes the uterus. We open the utero with mechanical suture, take out just the upper part of the body of the fetus, and intubate him, and then, with calm, perform the surgery. If these fetuses were born from a spontaneous delivery, the pediatrician will have problems to intubate him. And besides the oropharyngeal tumor, this baby probably will have underwent a perinatal asphyxia, worsening the prognosis. So this is a summary. Moderate or severe with amniotic fluid index of more than 30, and infrequent but have more associated anomalies. Insist in the study, the maternal blood sample, the fetal ultrasound, and genetic to try to find the cause. Never forget to make the assessment of cervical length to prevent the premature delivery. We will monitor the mild cases every 2 weeks and the severe cases every week. And remind that the treatment of polyhydramnios in less than 35 weeks with shortening of the cervical length, and in case of maternal discomfort, will be the amniotic drainage with an 18G and rapid aspiration. The quicker, the better.